Yes. So it's right at 9:30, so we'll go ahead and get started with a panel. So I would like to invite Dr. Sartaj Sibia up as one of our panelists, Dr. Will Sawyer as a panelist as well, and I believe Blake is standing outside the door, so we'll get him back in here. Please give your undivided attention to these three individuals, and we'll learn a lot about more cataract surgery. Thank you.
Shout if it's something that's silly or you disagree with, that'll be helpful. Okay. All right. Text message from Austin Taylor. They're waiting on you. Please come in the room. Okay. I'm here, man. All right. Was that first lecture good? Yeah? Okay. Some people are like, man, I want to hear about multifocality and blah, blah, blah. I don't know. I don't think I'm as good talking about that stuff, but the the patient conversation piece, the psychology piece. That's what interests me. So I hope that you found 10% of that useful. This is a little bit different. This is more real-world cases. And hey, what lens would you choose? During the break, there were some good questions about, hey, in this scenario, what would you do? And so I thought that having sort of a panel discussion around that would be useful for you guys. So thanks for allowing us to do that. I think maybe first what we can do is just introduce yourselves and talk a little bit about your practice. Start there. Can we get his mic on?
There you go.
There we go.
All right, I'm Will Sawyer. I'm in Texas, just a little west of Fort Worth, and I'm cornea, but most of my practice is general with cornea, and I do a lot of refractive cataract surgery. I also do refractive corneal surgery as well.
I'm Surtaz Sibia. I practice in South Florida in the Palm Beach County area. Oculoplastics trained initially, and then kind of shifted to cataract surgery right during the COVID years and post-COVID, when we had the huge influx of northerners come down and we got inundated and couldn't handle the volume of cataracts that came down here. And so that's really pushed it. I don't even do any eyelids anymore. So it's really changed my practice last 4 or 5 years.
Yeah, when Austin was telling me about our panelists, he's like, you got to have Surtaz up there. He's got a 100% conversion rate. And I was like, bullshit. He's like, no. He's like, this dude is 100% convert. Can you talk about why? I'm like, I asked you about that. Explain what that's about.
Yeah, so our practice really does have a conversion rate near 100%. I'd say 98%. And the 2% that don't convert, we have a residency program. Our residents then convert them and give them a free lens. So we have a 100% conversion rate. But realistically, I do 20 cataracts a week. About 75% are femtosecond lasers. The other 25% are manual technique, but they're paying for an LRI manually, or they're paying for a toric lens, or they're paying for a multifocal lens for the others. So I really, truly have a 100% conversion rate on that side of it. We have different packages in our practice, going from a basic package where they're actually paying us a few $100s for the drops that we put them on, the refraction, their topos and their OCTs and things like that, and a lid cleanser that we put them on. Then we have one step above where we go with our, we call it the high definition package with LRI. We're giving them a manual LRI versus a laser LRI, which is a little bit more expensive. And then we have our torics and we have our multifocal lenses. We've also dabbled a little bit with the advent of like the iHances and the monofocal plus, like people like to call those, which is one step lower than the multifocal lens, because I felt our practice was cannibalizing on the multifocals by offering the high definition package. And so our high definition package was right around the $800 range, and our multifocals are about $3,500. And the sweet spot, I think, is $2,000 to $2,400. So we then started using like the Invista Spire, which is off the market right now, but we'll be back in a few months. The iHance, the Rayner RAO 200E Ray 1 EMB lens, and that was the package where we said, we're going to give you distance and intermediate vision. You're going to use a 125 to 150 magnifier. And that really took off in our practice in the last year and a half. And so we've definitely moved to 100% conversion. And like I said, we've got residents in our program, so they pick up the other lenses that these manufacturers are giving them. They're giving them 20 lenses of each. So they can technically get maybe 80 or 100 cases on their own out of our practices and upgrade these patients to give them better lenses for free. And so that's really helped us a lot as well.
Very cool. Very cool. So case number one. This is a 59-year-old vet, comes in with a veterinarian, not a war veteran. Very different, my God. With cataracts, looking for vision correction, spectacle independence. Had LASIK, quote unquote, in the past. And this is the refraction, so hyperopic in both eyes, corrected in around 2030-ish. And you see this slit lamp photo. Did anybody put any cornea inlays in? Yeah, it's okay. This is a safe space. So I loved boast. I love to market myself, and so when I did the first corneal inlay in Louisiana with the raindrop, I made sure to put that on my CV. Like when you go to my website, and then I also was able to put also the first person to explant a corneal inlay in the state of Louisiana. Very embarrassing. Anyway, we did LASIK back in 2016 with a raindrop in the left eye. I went back and removed the raindrop in 2020. So the patient had it for about 4 years, and that's what the cornea looks like post raindrop removal. It looks like it's still there, right? Just from that little central haze there. Look at this topography. Not a whole lot jumping out. Looks like there's about a diopter or so of cell on the right eye. Can't really see the left over there, but otherwise Myers are looking okay. So panel, what's your approach to the post-corneal inlay patient who now seeks refractive cataract surgery? If you had a patient like this, how would you talk to them and educate them? What lenses might you think about?
I have not done a post-corneal inlay patient as of yet, so I don't have any experience with this. I'd probably refer to one of my corneal specialists in town.
Okay.
Yeah.
Will?
So yeah, I've done some of these cases, and what I have seen is the inlay eye won't quite get as good of quality of vision as the other eye afterwards. That little corneal opacity seems to be enough for refractive people to notice. So I want to set the right expectations on that. That if we're going to set both eyes for distance, you'll likely notice better quality out of the non-inlay eye. What was it? Which eye had the inlay?
Maybe the left eye?
Okay.
I don't know if the left.
Yeah.
So you wouldn't put like a trifocal in that eye?
No. So that would be the other thing, is I would completely stay away from a multifocal lens. However, I consider, EDOF lenses not multifocal lenses. I have those divided out.
Mm-hmm.
So I will still do an EDOF lens.
Maybe
but
in that eye.
Yeah,
Okay.
but not a multifocal.
All right. Well, let's see. So it looks like you're going to choose either a sort of monofocal with astigmatism management, or you're going to choose maybe an EDOF, depending on what their goals are. And this is kind of like what our plan slide is for every case. It's kind of like, here's your different lenses types. Here's your different ways to fix astigmatism. Are you using any tools like light delivery or aura or whatever in there? So what I did was an odyssey in the eye that did not have the inlay. And to your point, I did the EDOF with a toric piece on that eye that had the inlay in there. And the reason why I felt comfortable doing that is because even though that slit lamp photo looked horrible, and we see that in cringe, the patient was fine. They really had no complaints. It was the most reasonable patient ever. They were hanging out with that raindrop for like 4 years, and they had some near vision improvement, but not much. And so when it started to change a little bit, I took it out, and they were much happier. And so I don't know. I felt like I didn't want to push it with a trifocal. Probably could have, but and I think that you could have very easily done, like an iHands or even a Invista toric or your toric of choice monofocal in that left eye, and probably would have achieved a similar result. Does anybody do that routinely, where you have just as part of your surgical plan, you'll do a trifocal or multifocal in the non-dominant eye and a monofocal in the dominant? Does anybody do that? Yeah, just as your fastball, so you kind of custom match. So I think that can work really well, and so that's what we did in this case. Case number 2. This is a 58-year-old retired boxer who was a boxing coach and underwent LASIK 22 years ago. This guy says, I'm having some kind of issue with the flap. I remember that happened back then, and maybe they needed to do more surgery. It's hard to remember. Now he's coming in, he's got cataracts, maybe traumatic. This is boxing, still boxing, and he's seeking continued spectacle freedom. So the first thing is I say is, dude, you're 58. Stop boxing. This is what his refraction looks like. So doing okay in the right eye, left eye around 20/40-ish. And then you see this. So what do you guys see there? What are your thoughts on this clinical photo?
Yeah, that looks like epithelial downgrowth under the LASIK flap.
Yeah, yeah, which would make sense and be consistent with his history of like needing more surgery after I think his flap got dislodged or something from taking too many blows to the head. And it sort of matches with sort of this weird looking topographic manifestation. So that's kind of tracking. So what's your philosophy on post-LASIK with long-standing epi ingrowth patients who want cataract surgery and spectacle freedom? What kind of lenses are you thinking about? Do you use femto or not? What are your plans with the fellow eye if it has a normal flap appearance, which it does in this case?
Yeah, this one's a tough one. So expectations for sure. I'm telling them no matter how close we get you to zero, with that much of an irregular cornea, you once again will not notice as good a vision in that left eye as you do in the right. And there is no way we are ever going to make it as good as the other side. You could, because at this point, if that epithelial ingrowth is stable, I'm not lifting that flap again and scraping.
So you're not going to scrape it out?
Not if it's stable.
Okay.
I don't know how stable it is, though. You
Yeah,
seen it for
let's
a
say
while?
it's stable. Yeah,
Okay.
let's say the astigmatism has been the same.
Yeah, probably not, because you do run the risk then of it just regrowing and regrowing, and I've had to do flap amputations before for people whose epithelium wouldn't quit.
Yeah.
So, which is not a good place.
Yeah. Sartaz, what do you think? Would you use femto on this? Do you guys use femto or you do?
I use femto, yes.
I guess the concern is like, can you get through that epi ingrowth that you're going to get? Is there enough
Correct.
power to get through that opacity?
Yeah, that would be my concern on that side. I would probably not do femto on that eye. Other eye, yes. The concern as far as lens, I would definitely probably go towards a monofocal lens, maybe an EDOF or a monofocal plus lens. Multifocal lens in this eye, no, not an option in my opinion.
Okay. All right. So, and you would, go ahead. You would add something?
So I do a lot of light adjustables, and I would stay away from that in this because I think the corneal opacity will mess up the light adjustable treatment as well.
Okay. So so both of you guys are gonna do a monofocal in the epi ingrowth eye, and what about the fellow eye? They're wanting independence. Would you do like a trifocal in the other eye? It's healthy, doesn't have ingrowth.
I'd be fine with a multifocal in that other eye.
Yeah, yeah. I did exactly what you said. The epi ingrowth had been stable for years. I did not mess with it. If you saw that photo, it's kind of outside the visual axis, sort of tracking well with the topography. So I just did a plain old LI61 manual, no femto on that eye, and then I threw in an Odyssey on the other side. Patient's 20/30 plus. In that left eye, it's got some fluctuating sill, and is doing quite well in the other eye. So able to kind of save that. Would anybody have removed that epi ingrowth before? Some people, sometimes the right answer on the test is kind of not what we do in real life. I don't know many people who are ballsy enough to lift a 22-year-old flap and start scraping shit out of there, but they may mark that down on a test. I'm just curious if anybody does that in real life. Doesn't look like it. Okay, case number 3. 40-year-old guy comes in. He's got problems seeing distance. Sees well at distance and near with his contacts, but he's seeking a surgical solution to see far and near. And he has a friend who's enjoying his custom lens replacement from the Williamson Eye Center, his golfing buddy. So a slit lamp reveals a clear lens. It's a healthy eye. You see he's quite myopic. It's got some sill. Refracts down to 20/20. You see his topography and tomography and biometry and retina. At least in the left eye. I don't think the right eye is in this, but you can see the left eye, he's got some pretty symmetric with the rule cylinder. And that seems to be tracking well with his biometry. So what's your philosophy on highly myopic pre-presbyopes who've got a clear lens? How do you talk to them about expectations, and how is that different than how you might counsel other patients?
Well, you definitely have to talk to them about their near because they will not have the near vision that they're used to. And a good way of doing this is if you've dilated them in the office, have them throw their contacts in and show them, look, you can't see your phone now. Depending on what lens you choose, it could be like this, or you could you could have, with their contacts on, even give them a +2 to kind of simulate a multifocal and show them where that's at. And you can have them bring their phone in and realize, oh, I just can't hold this at my face. I can't sit there in bed like this anymore. I'm gonna have to put it out or use readers.
Yeah.
So that's a good way of getting it in their head.
Yeah, focal length is so weird for those high myopes because they really do, they think that this is reading. This is what you're supposed to do. And I'm like, dude, all you got to do is do this. And they say, well, no, that's ridiculous. I'm like this. And I'm like, no, you're not. Let's stop. We're not going to allow crazy to kind of creep in here. We're normal people. You're not like this. You're like this. This is different than this, right? And so, yeah, I mean, I say, listen, God didn't make a lens that gives you the near that you have. And even if he or she did, it would not be the lens that you want because that's the reason why you can't see shit far away, right? So we're trying to give you the best of both worlds. And so I think that's important. Anything to add there?
The other thing I'd add to them is just their high myopia, higher risk of retinal detachment at their age. I'd actually have them see a retina doctor beforehand in our practice.
What's your cutoff for that? Like if a
under-
-3 comes in, maybe you're not referring to retina.
Not, yeah, mine's like -5 and higher.
Yeah. Ours is -7, and I'm wondering if it should probably be lower. I don't see it on my Claris. I'm certainly not looking back there. And maybe I should make it lower. So what did I do in this person? Let's see. So what's your plan? Are you going to do LASIK OU? Are you going to do a toric ICL OU? Okay. Or are you doing a custom lens replacement or RLE, whatever you want to call it, with toric multifocals or EDOFs? What is y'all's plan? What are y'all going to offer this guy?
I'd offer him clear with a multifocal or EDOF.
Okay. Well,
I would personally offer him a clear with multifocal or EDOF, but that's because I don't do ICLs. But I do have
Shame
a guy
on
in
you,
my
shame on
practice
you.
who does. I know, I do have a guy in my practice who does, and actually that is actually a pretty good option for this patient because they're right at 40.
yep.
I mean, I'm 45 and I can still focus pretty near, so
Yeah.
I like my accommodation. I might want to try to keep that 5 to 7 years longer if I'm lucky.
It's funny when you're like 32 and you're answering this on the test. You're like, oh, they're 40 years old. They're not going to be able to see anything up close. And then you turn 40 and you're like, fuck, I can still see up close. Like, I don't know if, you know what I mean? Like, it's kind of funny how that happens. And so, yeah, that's exactly what I did. The ICL is the best shit ever. Is anybody doing ICLs? Do you agree it's like the best thing ever? You don't. Okay, you do. Well, I mean, to me, it is. I was just kind of a scaredy cat to do it for years, and my dad has been doing it for 20 years. So I was like, oh, all the -10 people who can't get LASIK, I'll send down there. And now that he's sort of semi-retired, he's like, dude, you got to do this. No one else is doing this in our market. It's amazing. You can do this. Like, you know how to do surgery. I was like, all right, and I picked it up, and it's by far not even close. My favorite procedure. I now offer it all the way down to -3. And a beautiful LASIK candidate, I would still choose ICL every single time almost. And the reason why is the reversibility is huge. You can't undo LASIK. Anytime you have that patient who, even with ICL, EVO, complains like a little halo there, I'm like, oh, I can take it out. And they're like, no. And I'm like, okay. So you're saying it's not that bad, right? So it gives you so much leverage for that mild to moderate unhappy patient versus with LASIK, you're going to have to hold that hand and baby for a while. Not that that's common. I mean, LASIK's amazing. Don't get me wrong. I've had LASIK on my own eye. But it's really nice having that piece to be able to explant very easily, by the way. It comes out super, super slick even 20 years later with the ICL. And the other piece, the other reason I like it is we really believe in our market of a vision plan for life. If someone wants to be free of spectacles, they want to have that forever if possible. And so let's say they're 22 years old or even 30 years old and they're a -7. You guys know that they'll likely drift a little bit over time, right? Myopic often. So I wouldn't be surprised if 5, 10, 15 years later they came back and they're like a -1. Well, then I can go back and do a primary LASIK on a cornea that's not been touched. So the opportunity versus doing a PRK enhancement, years later on someone who's had a -7 ablation, you're worried about epithelial hyperplasia, you're worried about overcorrecting, all that stuff. It's a lot more headache. And so while it's easy and it may be safe and comfortable for you to do LASIK, because it's what you know and it's what you're confident in, I would actually argue that ICL is a better play if you're considering the lifetime of that patient and that they probably will come back to you wanting further vision correction later in life. So that's what I did. Yeah, and that's the other piece is avoiding multifocality. Even though, it's funny, like someone comes in -7 +2 and you're like, God, they can't see anything. Like I'm going to slam dunk this bad boy. But oftentimes they sort of think about how they see with their contact lenses, right? And they're like, yeah, I get that when I take these out, I'm blind. Like, yeah, I get it. But when they're in, I see great. I love it, all right? And so sometimes a trifocal is not that, and they say, yeah, I'm 20/20 J1 without glasses and contacts. That's great. But when I have my contacts in, I saw better than I do now, right? We hear that all the time, right? And so that's yet another reason why, even in a 40-year-old like this patient, I chose ICL. Because to your point, I wouldn't be surprised if they maintain decent near vision for a long time. It could be 50 years, and they may tend to creep a little bit more myopic. Their reading vision may improve over time, right? So I could not see this patient for 20 years, and I wouldn't be shocked when it's cataract time. All of a sudden, they're 60 years old. So that's why I did that in this patient. Any comments with that, or move on? So case 4. This is a 48-year-old guy, comes in with sickle cell anemia, wants vision correction. He had LASIK 20 years ago. We have a theme here, a lot of post-refractive in our market. But his LASIK wore off, and he's been back in contacts for years. He sees a retina specialist. He had something lasered a few years ago. This is what his refraction is. So he's myopic with some SIL. Does see well with that prescription. And his slit lamp exam does show us that he has some trace nuclear sclerosis. So you see his pentacam here. And looks like he has, about 3 diopters or so of SIL on the right. And I don't have it memorized. Can you guys, how much SIL does he have on the left? Can you see that up front, Austin? Can't see it? So he had old peripheral PRP for NV. And so the question is, what are your considerations in treating a patient like this? So they have retina history, they've had prior refractive surgery, they have an early cataract. What's your fastball, Certez, for something like this?
So again, I'd make sure that his retina is okay as far as his retina doc clearing him. On this one, I don't think it's appropriate to take out his cataract at this point in time. I think you're looking at probably doing an ICL on this patient.
So even though he's got nuclear sclerosis?
Yeah, with trace, I don't know if I'd do that at this point in time.
Okay. All right. Any thoughts?
Just the retina history being myopic.
Yeah.
Yeah, that's a good point. Go back to his. Can you go back to his refraction?
Yeah. Sorry. There you go.
I mean, that's a very good point. Retinal patients, I really just tend to stay away from multifocals because of the decreased contrast, and
Has that changed the further along you've gotten in practice? Did you used to be more bold with that? I used to. I was slamming trifocals in like 8-cut RKs, and I was like, I can kind of make it work most of the time.
Yeah, it's definitely
now I'm like, I avoid that.
yeah, it's gotten less because we also have more lens options too.
Yeah.
The more options we get, why use the ones we're not as confident with? And
Yeah.
so I I don't know. I mean, I think you could go forward with anything, but probably a multifocal.
Okay, all right. So y'all are thinking some type of either ablation on the cornea, or maybe like a toric ICL or something like that. You're thinking if you did a lens replacement, you would use more of a monofocal. So what I did, I took your advice. I did more of a monofocal approach, toric monofocal. So bilateral custom lens replacement, because as you mentioned, not a real cataract, more of a California cataract. So I did the clear procedure with toric monofocals. He didn't like PRK. I didn't like the idea of PRK with already thin corneas. And he had a pretty big astigmatic treatment. And so I don't know. My thought was if I was going to touch him up, I'd be worried about epithelial hyperplasia. Yeah, question in the back.
Back to the topography, do you think that's more for us?
Hard to say. Just because the posterior elevation wasn't, like, the final D value wasn't super high, but you could argue that. This guy has been in the practice for a while. Refraction hadn't changed, but yet another reason why perhaps you wouldn't want to go on the cornea. My reasoning was, I think that they had a big treatment before. And I'm worried about the epithelial hyperplasia, and I'm worried about sort of chasing my tail. Plus, we've just shown you that they have some trace nuclear sclerosis, so we're approaching 50 years of age. I don't know. I don't think that. I think that getting the lens out is probably the best idea. And again, I didn't like the toric ICL because of the borderline cataract. Didn't like the idea of multifocality, to your point, because of the prior large ablation that this patient had, the retina history. And the patient wasn't excited about halo and glare. So that's kind of what I did. So case number 5, 60-year-old guy comes in. He had myopic LASIK 20 years ago. He's been back in bifocals for years. Now he's seeing poorly, and he'd like a solution to get out of glasses again. He's got a history of hypertension, insulin resistance. He works as a riverboat captain down here in New Orleans. And you look at his slit lamp exam, he does have some cortical spoking there. He's got some NS. You see his LASIK flaps, and you see that he is definitely a hyperope with some poor vision, especially on the right eye. So you look at his tomography, and nothing dramatic jumping out at you. Very low cylinder. You can see his ablation profile there from his pachymetry. His biometry really is sort of matching fairly well, and is consistent with the tomography. We use the 700 in our practice. So the question for the panel is, what's your approach for IOL in patients who have diabetes or is insulin resistant? And what about those patients who really are dependent on good vision at night? There's a few disciplines, being a pilot in an airplane, being a riverboat pilot, being an Uber or truck driver, that you got to have great nighttime vision. So I wonder if that would inform your IOL choice.
On this patient, I would probably go with like a Symphony or Vivity as an option, and maybe decenter one, maybe, or defocus by half a diopter. And his non-dominant eye would be an option, or I'd go with monofocals. Would be my options.
Okay.
Yeah, I think that's an excellent approach. On diabetics, it really depends on their retinal status. I see a ton of diabetics in the practice, and a lot of people now have hemoglobin A1Cs around 5, which is kind of crazy.
Yeah.
But
Let's say their A1C is like 9.
Yeah, that makes it a little tougher.
Would you do a trifocal in them, or even if their retina is beautiful? I think I do. I don't know that I look, well, I'm being honest, I'm not sure that I look at their A1C. I should. It sounds awful, but it's also the truth. I'm looking at their retina picture. I'm like, oh, that's crystal clear. There's no BDR at all. But thinking back in training, they were like, oh no, this patient has uncontrolled diabetes. What if they get CME or Irvine gas after this? Maybe I should be looking at that.
I'm actually kind of like you. If they don't have any retinopathy, they don't have retinopathy.
Yeah.
It's, maybe that's not the right approach, but.
Our retina colleagues would throw their shoe at us.
Right. But yeah. But,
All right, so what would you do in this patient?
oh, I 100% agree.
Same thing. So you're going to do, sounds like a sort of an eat-off approach, maybe a little bit of micro-mono. So that minus 50 offshoot is huge, especially in these, monofocal plus categories. Those people can be J1 people, J2 people. Of course, J1 doesn't exist in our clinic. J2 is the smallest line, but they're routinely J2 with just a minus a half. And so that's a reasonable plan, and it's exactly what I chose as well. So I did the Ray 1 EMV from Rayner. Who here has used the EMV lens from Rayner? Okay, so I consult with this company, but even if I didn't, I would tell you this is a game changer, and everybody here should be doing it. The reason you didn't see a lot of hands go up is this is a Rayner lens, right? So it's from the UK. They don't have a big presence here in the United States. They're trying to change that now, but it's been my fastball. It kind of, in my opinion, it kind of does. What's the J&J? iHance. It kind of does what iHance like said it was going to do, And our colleagues around the country, around in other countries, sort of this is like interchangeable with Vivity. Who's got you? Did you put a Vivity in your dad's eye? Where's your dad? Who's got a Vivity? Yeah, you have Vivity. Yeah. So this is kind of like they said this delivers even better vision and better range than a Vivity, and there's no circles, there's no rings, it's not diffractive at all. It uses positive spherical aberration, so it plays off the natural spherical aberration of the cornea. But what's cool is here in the United States, they did not get an option 3 presbyopia designation, and therefore it's a relatively cheap lens. It's like $150 versus $1,000 for a Vivity or a Odyssey or whatever. And so we still position this in our option 3 package, right? So we consider it a extended depth of focus lens. It's very critical that you change your billing sheets and that you explicitly state that the money that they're paying is not for the lens itself. They're paying for the refractive package, which includes the astigmatic management, the pre-op diagnostics, and a included LASIK enhancement if needed, right? So you could literally put an LRI in an eye and charge $50,000 if you wanted to. That's technically legal. Nobody would come to you, but it's legal. And so for us, this EMV, besides first and foremost delivering excellent vision and having happy patients, it's been a huge boost on the business side. Literally, I mean, think about it. We save almost $2,000 per patient than if I had put a Vivity or a Symphony in this eye. So anyway, I do a minus 75 offshoot, a little bit more than a minus 50 in these people. 3 months later, very happy. Really no dysphotopsias at all. I never hear people complain about halo glare starburst. I actually tell them that they're likely not going to have halo glare starburst with this lens. And I'm rarely surprised if they do present with that. So that's been a good lens everybody should try out. Case number 6, just a couple more here. This is a 53-year-old guy. He's got some cortical spoking. He's looking for vision correction and spectacle independence. He has a history of contact lens overwear. He said, "Doc, I'm going to be honest with you. I was terrible with my contacts. I had all kinds of infections, and I'm ready to be done with this." You see his refraction there, so he's a myope and got 20/30 vision. So you see his clinical exam photo here on the slit lamp, and you see sort of these like peripheral, what looks like sort of old ulcerations from contact lens overwear. His tomography isn't really too wild here. Maybe some inferior steepening. You see a little bit of posterior elevation in the yellow on the bell and ambrosia on the right eye, but nothing scary, and a typical pachymetry. So what's your approach for the patient with a history of corneal ulcers who now seeks refractive cataract surgery? And what about patients with irregular sill, and some form fruit. So that's what I was referring to with that on the right eye there. You see that the back difference map. You have a little bit of yellowing, a little bit of inferior steepening on that side. So just wondering kind of if that may input at all to what you're going to choose lens-wise for these people.
So the ulcer scars really depends on where they are and how much of an irregularity they're causing on topography for me as to what lens I'll choose. I mean, the most common lens I rule out for patients is multifocal lenses, and irregular corneas or scars, I'll rule that out. A light adjustable, if the scar is going to be in the way of my treatment, I'll rule it out.
Just because you're worried about the light delivery device getting through it, basically?
Yeah,
Okay.
yeah,
Kind of
yeah.
like, almost like a
Basically
femto.
getting a odd portion of the lens not treated correctly and creating an odd, an irregular astigmatism in the LAL lens.
Okay.
So with irregular sill and with
Form fruit.
one of the big things I watch out for is what I'm doing with any kind of astigmatism correction matching their refraction. If their refraction is wildly different than my topography or my Ks on the IOL master, then I'm going to actually lean closer to treating their refraction than what's being measured.
Just because you believe more in what they're objectively telling you they like vision-wise?
Yeah,
Or
so-
subjectively telling
Right,
you what they like
right.
vision-wise?
And obviously,
Yeah.
it depends on how bad their cataract is, how
Sure.
much I can trust that refraction and things like that.
Okay.
But those ones there are one of my least favorites is hyperopic LASIK corneas.
Yeah, that's brutal.
All the machines have a hard time measuring that.
Yeah. Sir Taz, what do you think?
I agree on the irregular astigmatism part. You definitely have to be very careful on what their refraction is versus what they're really seeing, and looking at what their subjective vision is. As far as lenses, yeah, I would eliminate a multifocal on this patient right off the top.
Okay.
I think it would have to be a toric in that, maybe a low power toric if needed, for that form pressed keratoconus, depending on what our measurements are. But monovision would be an option because they've worn contact lenses, they've done it before. I'd offer them with a monofocal lens or a toric lens.
Okay, all right. So in that right eye, I did an EMV, EDOF, right? For the same reasons you guys said, I wasn't looking for a diffractive option in a form fruit eye. I don't know. I think that I kind of go back and forth on if that was a good idea. Probably would have gotten the same result with a monofocal. Why try to play off the spherical aberration in a funky cornea that could get funkier. But I don't know. It ended up working out very well. There's other things you could consider. You could consider an IC8. You could consider certainly an LAL. All would be reasonable options. It seems like for the longest time at the ophthalmology congresses, at least for past couple years, like every answer was like LAL or IC8, like it was the savior of everything. And now we've realized what a big pain in the ass LAL can be. And so we're trying to do less of them, even though it is awesome and it is the savior most of the time. Sometimes it's not. It's fun. There's a thing called, this is actually funny. There's a thing called new lens euphoria. Has anybody ever heard of new lens euphoria? It's hilarious. So you got to Google new lens euphoria. It was the editor's note in CRST. Stephen Dell coined the term, and if you listen to him sort of present this syndrome that ophthalmologists get when a new lens comes out, and it's just the best thing since sliced bread. And then like 3 months go by, and it's like, this is the worst lens ever. It's so funny, and we all get it, right? So new lens euphoria CRST, if you Google that, you'll have a giggle laughing at ourselves and how silly we can be. So case number 7, 19-year-old. All right, we got a baby coming in here. It's got diabetes and horrible diabetes, and has anterior subcapsular cataracts and PSC, as they usually do in this case, and doesn't like glasses. Has had an issue finding contacts that fit well, which is interesting. And you see they have very poor vision, and they're coming to you for a solution. And this is what their tomography looks like. What do y'all think about that tomography and that right eye up top? Definitely a trifocal in this eye?
No.
No? Okay. All right.
What did the cornea look like?
Yeah, I mean, so cornea looked fine to me on slit lamp exam, but just showing you here that the right eye obviously has a lot of disease. That's probably the reason why contacts don't fit well, quote unquote, is because they have keratoconus in that right eye. And it looks like they're getting kind of form frusty over there in that left eye too. That looks pretty irregular. And so that's going to sort of factor in here. So we're looking at, is this progressing? This is sort of the little checklist. Who does cross-linking here? God bless you, community service. We do it in our office too. It's a pain, but no one does it. We got to do it. It's important, especially in teenagers, for God's sakes. This eye had an increase of a diopter or more, over the past couple years, and so both right and left eye. And so we thought, okay, this is progressing keratoconus in a 19-year-old. So what's your philosophy on very young patients receiving refractive cataract surgery? What lenses are you thinking about for them? And then specifically in this case, what about patients with a history of keratoconus? And then people are going to know, do you just take the cataract out? Do you do cross-linking first? If you do cross-linking first, how long do you wait before you, all that?
I would definitely send him off to one of my cornea colleagues to do the corneal cross-linking. I'd probably wait 3 to 6 months before I took his cataract out. And I would offer him a EDOF in his dominant eye, non-dominant eye. I'd do a multifocal lens.
Okay. What do you think?
I agree with the cross-linking and then waiting 3 to 6 months. Man, one of the hard things about this is this person's 19 with a cataract. When we were kind of talking about the blood sugar thing, this may be the exception of the rule that they worry me. They're 19, their blood sugar's been so bad they've already got cataracts. What's that retina going to do over time? Like I said, don't usually think about it, but this time I am.
So you're going to be less adventurous,
I'm going to be much less
if this was
adventurous on this
was your
one.
child.
Right. At first, for a second, with keratoconus, I love the idea of an IC8, but I don't love the idea of blocking retina's view with as young as this person is either. So, I think I'm going monofocal on this.
So you're going to cross-link first. You're going to wait. You said 3 to 6 months, and then you're going to do a very boring, shameful monofocal lens. Okay. All right. I don't remember what I did. What did I do? Hopefully did I do that? Okay. So, I cross-link the eye, awaiting corneal stabilization. We typically wait a year. I don't know. Bill Trattler yells at me. He's like, Blake, we have people progressing like even past 12 months. So at least wait a year before you do your biometry measures for someone who got cross-linked. So we wait a year. I think somebody mentioned the IC8. Definitely considering that in that right eye. It's kind of funky. And definitely a monofocal toric in the other. I think that, my dad did like 10,000 RK back in the day, and so that's the gift that keeps on giving. They're all coming to me now for cataract surgery. And, I've just hit a few really big home runs. It's like with IC8 and those funky corneas. And it's a great feeling. It's like a buzzer beater, at the end of the game. Nothing but net for an eye that you thought was going to be, totally trash, and they're happy. To be balanced, I've also had some people that it's been terrible on, and I've explanted 2 of them just in the past year. And a lot of that has to do with the sort of central aperture of the cornea and how much of a swing, how many diopters they're changing right there in that center of the cornea. So you can look at that very closely on your tomography. If it's not a huge jump, usually with that pinhole effect, you can get a good outcome. Other times it's horrible, and so be prepared to explant it. Yagging is also a pain. You have to do it sort of peripherally, and you can ding that the little inlay thing if you're even close. So that'll look kind of ugly to your ODs, and they'll send it back to you all confused and make you feel like a failure. So yet another sort of trial and tribulation with IC8. But when it works, it works. Case 8, 47-year-old guy comes in. He's got reading glasses and sees well at distance. He's never worn glasses or contacts in his life. This dude has seen great forever. He's seeking a surgical solution to see up close. He's got no other complaints. Also works as a riverboat captain. That's 2 riverboat captains today. He does have some trace spoking, but otherwise a really healthy eye. He's 20/20 J5, uncorrected. All right, so this guy sees pretty well. His OPD3 is pretty vanilla. Not a whole lot going on there. The sill doesn't look super regular, but it's small. And similarly, the tomography kind of shows that he's consistent with the topography. Nothing really scaring you here. So what's your philosophy on operating on the plano presbyope? Who's got barely any cataract, or let's call it a clear lens. Are you seeking out corneal laser vision correction, or do you go with an IOL? And how do you handle those expectations?
Yeah, that one's a tough one. This one feels like a landmine to me because he's 20/20 J5. So I'm probably trying to talk him out of everything. And in fact, if I'm having a hard time talking about things, I'm sending him for a multifocal contact lens fit.
I thought you were going to say psych eval.
Right. To make him see how that vision works. I know it's not the same as an IOL, but at least it'll.
Hopefully he won't like it, and then you can get out of surgery.
Yes, that's exactly right. That is exactly.
You're
right.
setting him up for failure.
Ooh,
I
yeah,
love manipulation. Did I just say that out loud? No, I guess I did.
I would do the similar. I don't know if I'd go with a multifocal contact. I'd probably just have one contact lens, aim for like maybe -1, do a little bit of monovision on that eye, and then with that, this is another option that we have without surgery. And then he takes it out when he's doing his riverboat captaining, because that's going to be an issue sometimes, I guess, as well. So that would be an option. And then depending on how he did on that, eventually over the next few years, and maybe consider it clear with EDOFs.
Okay. So, we're not saying no to surgery. We're just saying maybe not right now. So I did exactly that. We need to find something we disagree on. He failed a monovision contact lens trial, which I sort of preordained that he would fail. We did a trial of Vuity, right? This amazing drop that works in like 10% of patients. So hopefully they're not sponsoring the meeting. So yeah, we said no surgery. Okay, and like I said, oftentimes, especially when you're doing a tremendous volume of surgery, it's kind of like a blip in the matrix when you're like, oh, I'm not going to operate on this person. It's like, yeah, dude, you don't have to. It's very powerful to choose not to operate on somebody. It's funny. Sometimes we do this with patients with unrealistic expectations. Those engineers that come in, like I said, I do them, but my sort of one thing that happens that's an absolute no is if they're a jerk to my staff. If one of the girls comes in and says, this guy was a total ass, please don't operate on him, I'm not touching that person. And to look at someone in the eye and say, I've considered your case. You do have a cataract there, but I've decided not to take the case. It's like a complete, they're like, you're what? Aren't you the guy on the billboard saying we do cataracts? I'm like, yeah, I'm that guy. I've chosen not to take your case. It's pretty powerful. And actually what they do is they beg for you to do their surgery. They'll call, and send emails saying, hey, I'm so sorry I was rude to your team. I, had a bad day, blah, blah, blah. And it's like, no, there's other eye doctors that can do the surgery. Anyway, in this case, the reason why I didn't take on the case is because, like I said, 2020 J5, young guy. And I've gotten burned a few times, again, being super aggressive because he's J5. He's not J1. And he does have an issue, or else he's not in your office for no reason. And I've slammed in a trifocal, and they've been just miserable. Not a lot, but a couple of them. And one or two of those in your market, Baton Rouge, Louisiana is 250,000 people in the town, small town. Someone pays $12,000 for a lens replacement. Yeah, they're J1 plus, but they hate their driving vision. They can't see their golf ball because of contrast issues. All that stuff. If you have one or two of those in your market, it can really kind of burn you. And so now, I'm less aggressive in a plano presbyope who's got decent vision. They're J5, but they're not J10. And if they push me and they twist my arm, I do the whole song and dance of multifocal contacts and all that stuff, and really dramatically underselling the quality of the vision. Oftentimes, actually the vast majority of the time, they do just fine. But the one or two that don't, that's 100%, for them, and so that's kind of what pushed me in this deal. And just very last case here, we just got a couple minutes left. 58-year-old guy comes in for cataract consult looking for vision correction, spectacle independence. His contact lenses don't fit well. That's kind of a common theme as well. You can see his refraction. He's hyperopic. He's got some astigmatism there. Sees really poorly in the left eye, it looks like. Does pretty good on the right side. Clean macula. And you sort of see his topography there. Looks a bit crab-clawy. Doesn't look super normal. Looks like the left eye is worse than the right. It's got, over 3 diopters of irregular sill. And then you look in here, you see he's got some Goutte-looking stuff there. So what's your approach for the patient with keratoconus and Fuchs, who now seeks refractive cataract surgery? How do you prioritize choosing the time in between cross-linking, DMAC, phaco? They kind of need everything, right? How would you take on this case?
So,
Do you do DMAC?
I do.
You do endothelials?
Yeah.
Okay, cool.
So, with I'd prioritize cross-linking first if he's progressing. Now he's how old?
Oh,
He's like 58.
50-ish maybe.
Yeah.
Yeah.
So he may not be progressing anymore.
Okay.
So,
he may have cross-linked himself.
He may have cross-linked himself, and so he.
That happens. Maybe you get older.
Yeah.
Cornea
I mean,
hardens.
most keratoconus eventually stabilizes.
Yeah.
And so you need time. You basically need time to see progression. If he's progressing, cross-linking first, waiting, and then the Fuchs is always, well, I'm not pulling a transplant on somebody until they need a transplant. Or if they've got, if I know that they need cataract surgery and I know that they're going to have edema afterwards, to me they need a transplant also.
Yeah.
On keratoconus, a lot of times I like to use a DSEC instead because I feel like I'm giving them a little more stroma and possibly stabilizing that cornea a little better.
Okay.
Keratoconus corneas are, you can't trust them.
Yeah.
They're very floppy corneas. But when do you do the phaco? That's kind of the hard thing.
Yeah. What lens are you thinking? So with a cone, or Certaz, what lens are you thinking with a keratoconus?
Maybe an IC8 versus a monofocal, maybe a toric if the astigmatism lets me put a toric in, but definitely monofocal. And if I think they're going to need a DSEC or DMAC, I would aim for -1.
Okay. And
My
why is
targeting. Because my cornea colleagues tell me aim for -1, but because when they,
That's what I was told.
Because when they do the there's a shift in their refractive power after they have the desync.
Yeah, so you want to aim a little bit myopic. Yep, perfect. So what I did, I had the patient sent to cornea for an endothelial cell count, right? I don't have one of those machines. And for a scleral fitting, waiting for 6 months to repeat the endo count along with a topography. Because the age and stable topography and the endo count, the plan was for phaco with monofocals, and then sclerals after. We'll monitor the need for DMEC or CXL in the future. So it's exactly what you said. I mean, my cornea surgeon in my market, he's not going to do a DMEC if someone's got mild to moderate Fuchs. He's going to say, hey, listen, we'll do endo count. Maybe we'll have to do it after, counsel the patient to that. No big deal. And cross-linking at this age, there's been no progression. There's no need to cross-link them just because. And then the last sort of word that I'll say is, does anybody have a good scleral fitter in their market? It's a game changer. My God. And many of the ODs call themselves scleral contact lens fitters. Just like a lot of cataract surgeons say, I'm a refractive cataract surgeon, and you start to talk to them and you realize there's a dramatic difference. So if they do 1 or 2 sclerals a year, they fit scleral contacts. The guy in my practice does 20 a month. And I'm just going to tell you, that shit is magic. I mean, it takes funky corneas and it does things that no IC8 or LAL can ever do. So I get that it's difficult and some people can't do it for a lot of reasons, but if you can teach them to do a scleral contact lens in a funky cornea, there's just nothing that's going to provide that level of vision. So in this case, the guy was used to it, and so that's what we did. I hope these cases were interesting. I tried to do a mix of all different stuff. It's been awesome being here. Thank you to the panel. Thanks for inviting me.